Welcome back to my talk on mast cell activation, the second part. In the first part, I covered what mast cells are, how they fit into the whole long COVID process, the symptoms, and how do we make the diagnosis of mast cell activation. In this second part, I will cover the specific treatment of mast cell activation, MCAS, as well as the general management of long COVID. References and links and resources are in the show notes below. As I've said before, any advice, diagnoses, treatments that I mention in my talks should only be considered after discussion with your own GP or qualified health professional. So here we go. Part 2 on mast cell activation and long COVID. So, what are the specific treatments of MCAS? If I go back now for one moment about mast cells, so just a gentle quick reminder, mast cells basically are throughout the body, in the tissues and circulating. On the surface of the mast cells, there are two receptors, okay? They are called the H1 and H2 receptors, and H stands for histamine. When the receptor is triggered, the mast cell breaks open and releases its contents, all those inflammatory chemicals that I listed previously, the majority of which is histamine. This process, again, like I said, is called degranulation. And so, to treat mast cell activation, we need to block those H1 and H2 receptors to stop the process of degranulation. And so, we do this by giving H1 and H2 blocker drugs. Simple, really. So, firstly, H1 blockers, a histamine 1 blocker, an antihistamine. Okay. We use second generation antihistamines that don't cross the blood-brain barrier. Unlike the first generation old-fashioned antihistamines, Piriton, chlorphenamine, which crosses the blood-brain barrier and then causes sedation. We don't want that. Second generation antihistamines there are a number of them. The most frequently prescribed are cetirizine at 10 milligrams, fexofenadine at 180 milligrams, and loratadine at 10 milligrams. Their licensed dose is for use on a once daily basis. Their licensed indications are for seasonal allergic rhinitis. So allergic process on a seasonal basis for nasal symptoms as a result of an allergic process. Rhinitis is another word for runny nose. And also it's got the other licenses for chronic idiopathic urticaria. So chronic, so continuous, idiopathic. The word idiopathic means there's no known reason, and urticaria is basically fancy medical name for hives. However, those doses that I recommended are, as I say, the licensed dose. However, much higher doses are prescribed by specialists. The dermatologists prescribe it for solar urticaria, so hives as a result of UV light, sunshine, and idiopathic angioedema, sort of swelling of the lips and tongues, prescribed by the allergy doctors. And they prescribe it at much higher doses, but this is based on experience. These drugs have been around a long time. Piriton's been around 50-something years, and these newer second generations, probably 20 years. So they prescribe at much higher doses, Cetirizine, for example, is often prescribed at 20 milligrams twice a day, so 40 milligrams total, as opposed to the 10 milligrams licensed dose. Loratadine, likewise. Fexofenadine, 360 milligrams twice daily. And it's, like I said, the dermatologists and the allergists feel very comfortable prescribing of this. And then they get GPs to prescribe at that dose level. And so they do, which is great. With their use in mast cell activation, at higher doses, patients should be informed that actually, this isn't the licensed dosage. And so the dosage should be discussed with the patient's GP. And likewise, it's off-label because it's not licensed to treat long COVID mast cell activation. As I say, it's just rhinitis and chronic idiopathic urticaria. And so, the patient needs to be warned of that, but, at the same time reassured that actually these doses are used quite commonly by those specialists and backed up by a lot of clinical experience now. Those 3 second-generation antihistamines are available over the counter. You can actually go and buy them yourself. So cetirizine is Zytec, loratadine is Claritin, fexofenadine is Telfast. Or you can buy, the Boots or Superdrug's own label equivalent. The potential side effects, according to the BNF, the British National Formulary, that's the drug side effect Bible for doctors, is appetite suppression, leading to weight gain. A few patients I've come across who've said that they've gained weight when they've put themselves on antihistamines. Rarer ones are sedation, headache, nausea, dizziness, but they are rare. Cetirizine is safe with patients on SSRIs, antidepressants. There's no prolongation of the QT prolongation with up to 6 times the normal dose. So there's reference to that in the show notes. The potency of antihistamines is an interesting one. I found this somewhere that in descending order, cetirizine is the strongest, next is fexofenadine, and next is loratadine. My experience, and so anecdotally, in the long COVID setting, is that I've had patients who have taken antihistamines for their MCAS symptoms, their hives or their respiratory symptoms, but they've said, "Oh, incidentally, doctor, the fatigue, my long COVID fatigue is reduced." And also, incidentally, I've had another patient who said my brain fog is improved as well. So, in a way, it's worth trialing, because it basically you've got nothing to lose. So not only for the MCAS, so consider it for those other long COVID symptoms. And the other thing is just to note that loratadine is one of the antihistamines it is the antihistamine that has been chosen for research of MCAS by the NIHR. Stimulate ICP trial. So again, as a reference to that, that's interesting. It's used alongside famotidine. We'll come on to that in a minute. So that's H1 blocker, and now on to H2 blocker. Okay, otherwise known as a histamine 2 H2 receptor antagonist. So the one that's used in long COVID mast cell activation is famotidine, 20 milligram tablet. Famotidine is from the family of anti-acid indigestion drugs, following on from cimetidine and ranitidine, both of which are not recommended due to side effects and potential harm. Famotidine, as I say, is in the same family licensed for treatment of gastric ulceration, duodenal ulceration, and reflux esophagitis, so acid coming up the gullet, the esophagus. And its licensed dose is twice daily for acid reflux, acid coming up the gullet. Famotidine blocks the H2 receptors. So there are lots of these H2 receptors that are found in the gastric lining and the gut lining thereafter. So it blocks the degranulation of the mast cells in those places. But it also works on T cells. And a T cell is an immune white blood cell. Excuse me. Now, basically, famotidine can reduce T helper cells and T killer cells. It's been found that's one of its actions. So, in other words, it's good news because it basically is dampening down the inflammatory process, and so therefore there's less excessive inflammatory flare. The other thing that's interesting about famotidine is it acts on the vagus nerve, and that also helps prevent excessive release of inflammatory components, the cytokines. So H2 blockers augment the effects of the H1 antihistamines. They are working together. H2 blockers working together synergistically with the H2, with the H1 blockers, H2 and H1 working together. In a study by Glynn et al., where they prescribed H1 and H2 blockers, they found that the combined effects of those two improved all symptoms except dysautonomia, interestingly enough. So again, there's an interesting paper in the show notes below. The potential side effects of famotidine, the anti-acid H2 blocker, according again to the BNF, Doctor's Bible, are uncommon. Appetite slightly decreased, dry mouth, taste altered, vomiting. Never come across any of those symptoms in my professional career as a GP, and certainly not now in long COVID. However, physicians are also prescribing it on off-label because, as I say, it's only labelled for gastric anti-acid, but they're also prescribing it at much higher dose, 20 milligrams twice daily or 40 milligrams once daily. Okay. Again, this is not available over the counter from Boots or Superdrug, but ironically, it can be purchased online. You know, you can purchase anything online, can't you? But remember, if you do that, if you want to go down that route, remember the excellent NHS advice on online drug purchasing. Again, I'll put a link in the show notes below. Dangers of buying medicines online, in inverted commas. NHS England, UK. So regarding the dose, I did mention that higher doses are suggested for MCAS. My usual advice to patients is initially take it once daily for a week. If the response is extremely satisfactory, an increased dose is not necessary, obviously. If, however, the dose is nil or marginal, an increased dose to twice a day after a week is reasonable. And as long as it's well tolerated without any side effects, it's safe. However, remember what I always say regarding recommendations in my talks, as stated in my show notes below. Any further increase in dose level should only be undertaken with your GP's approval, medical guidance and supervision. The reason for this is that high doses, like I said before, are off-label and also off-license. So patients should be aware of this. when in doubt, ask your GP. For those patients who are taking H1 and H2 blockers and find them beneficial, a question that keeps cropping up in the long COVID clinics are, patients asking, well, how long should I take these treatments for? And what I usually say is this: if the symptoms improve, these medicines could be continued for 3 months. Stop at that point. If you want, you can wean off and then stop, or just stop abruptly. But restart if the symptoms return upon discontinuation. So if your symptoms come back when you've come off your H1, H2 blockers, your MCAS treatment, your symptoms come back, you're going to want to start them again, aren't you? Obviously. So run it for another 3 months and then trial off again. Hopefully, sooner or later, the whole process will have burnt itself out and you'll be able to come off the meds. You don't want to be on meds if you don't need to be on meds. So remember, trial off, restart if symptoms come back. If they don't come back, problems sorted, you don't need to continue them. So that's the first line treatment for mast cell activation, MCAS. If, however, the response is only mild, there are a number of second-line treatments that you can try. Mast cell stabilizers is one group of medicines to block the degranulation, because it stabilized the cell membrane. The mast cell membrane has been stabilized, and it prevents, therefore, the release of the chemicals, i.e. histamine and all the rest of the bad boy mediators. There are a couple of those mast cell stabilizers. Ketotifen, which in actual fact is an H1 antihistamine, second generation, but it's been found to have mast cell stabilizing properties. It's a leukotriene, if you want to get technical, antagonist activity as well. So 1 or 2 milligrams twice daily. It's used to prevent asthma attacks in people with brittle asthma. The other mast cell stabilizer is sodium chromoglycate. Most of us know this as Opticron. We're familiar with this for Opticron drops for itchy hay fever eyes. But it's also available as a tablet, 100 milligram tablet. It's licensed for treatment of mastocystis, mast cell activation syndrome, but it's incredibly expensive. It's not used for these. It's not used for this really these days because it's been replaced by a better preventer, something called montelukast. It's again like ketotifen. It's a anti-leukotriene antagonist inhibitor. 10 milligrams daily is used for exercise-induced asthma, allergic rhinitis, urticaria. It's not over the counter. You can't go and buy it. It's a prescription-only drug. But it is something else that a number of patients use as second line, either on its own or alongside their H1, H2. You may also have heard about quercetin. What is quercetin? This is a plant polyphenol that's contained naturally in the skins of the fruits and vegetables and onions, and also in the actual tissues of the onions and vegetables. It can be bought as a health supplement, health food shops, 1,000 milligrams daily as per label. It inhibits the release of histamine and prostaglandins, so inflammatory mediators, leukotrienes. But like all herbal supplements, we've got to be aware of the possibility of interactions with prescribed drugs. So, like I said, this is common to all natural supplements and herbal remedies. So, look at the small print on the label. You may well have also heard of the low histamine diet for MCAS. The thinking behind that is that dietary ingested histamine tops up the histamine bucket in that we've got in ourselves, okay, in our circulation. And so therefore, like I said, the thinking behind is that if you adopt a low histamine diet, it means that there's going to be less of a loading of histamine into the histamine bucket. But actually, there's no hard evidence that low histamine diet helps in long COVID. Histamine is typically in hard cheeses, smoked meats, oranges, bananas, spinach, tomatoes, wine and beer, peanuts, tree nuts, tinned, pickled fish like sardines. So I mean, it's ubiquitous. It's everywhere. It's in many food sources, and so it's quite difficult to have a strict low histamine diet. I think it's interesting that when you look at the Association of UK Dietitians, they say that actually they're not wholly in favour of a low histamine diet for long COVID. They prefer and recommend the Mediterranean diet, fruit, veg and oily fish, and which, like I said, a strict low histamine diet doesn't have all those beneficial factors that are contained in a Mediterranean diet. But like everything, it all comes down to what works for you. If you've put yourself on a low histamine diet and suddenly your MCAS symptoms are dealt with, that you're no longer troubled by them, carry on. You're not going to want to reintroduce histamine, are you? So there's no harm in that. No harm in trying the low histamine diet. But my advice would be, if you've not noticed a difference in your MCAS symptoms, an improvement of those symptoms, after, say, 2-3 months, I'd stop the low histamine diet and swing back to a mixed balanced diet, the Mediterranean diet. And so, what else can we do to help the recovery from long COVID? Well, like I said, I think it's important to take a holistic view, a sort of a general whole person view. We need to think about nutrition, we need to think about sleep, we need to think about mind, body. So we've touched a bit on the nutrition side already when we're talking about the low histamine diet. So basically, all in favour of a mixed balanced diet, the Mediterranean diet, because it contains all the minerals and the vitamins and the polyphenols, the antioxidants that you need. It gives you the building blocks for repair, the antioxidants, as I said, the anti-inflammatory agents, but also it provides you with prebiotic fibre to nourish the gut microbiota, the friendly gut bacteria. I cover this more fully in my talk on long COVID gut. A healthy gut flora, so important for supporting the immune system, for production of vitamins and hormones and chemicals, neurotransmitters, to actually go one step further, have some omega-3 fish oil, essential fatty acid for immune support, and vitamin D. Again, that's helpful for one of its many functions is to support the immune system. So that's diet dealt with. Sleep, the other sort of whole person approach. We've got to think about sleep, the great healer, to refresh and repair. We've got to support the day-night cycle, the circadian rhythm, because that sort of governs the release of various hormones, particularly growth hormone, which is a sort of a restorative repair hormone that's mostly secreted at night. So, sleep hygiene, no mobiles or screens, within an hour of going to turn the lights off at night. Sleep enhancing effects of Piriton, the sedating antihistamine, is not unreasonable. Magnesium is said to improve that, and they're backed up by studies. Melatonin, likewise. I cover this in my talk on sleep disturbance in Long COVID. Plus, I think it's important to tackle all those worries, the turbo brain of anxiety that leads to fight and flight, adrenaline, sympathetic overload. We need to address these with mind-body techniques such as meditation or mindfulness. You can download the Headspace app, the Calm app. It's a reasonable price. There are many studies that show that it reduces stress and anxiety. And then there are the other sort of mind-body strategies such as yoga or Tai Chi. Again, backed up by lots of studies that demonstrate its effect for stress and anxiety reduction. And then there's this sort of, if you like, the whole long COVID management process and management of fatigue and remembering, pace, plan, prioritize. Pacing, the process of balancing activity, physical, mental, and emotional, with rest. With pacing, you learn your limitations. You learn your limitations so you can plan how you use your energy, and you can conserve the energy as well as use it, not to run out of it, not to push on through. You learn how to pace yourself to say no, that's enough, stop, rest. Again, like I said before, I cover this more fully in my talk on fatigue, on COVID fatigue. Beside all the above, there is the general advice from trusted resources for long COVID, and I've put a couple of links in the descriptor in the show notes below. So there we are. That's the conclusion. That concludes my second part of Mast Cell Activation and Long COVID, MCAS, otherwise abbreviated to, which follows on from the first part that I gave earlier. So I hope you found that helpful. As I mentioned at the start, any advice, diagnoses, treatments that I mention should only be considered after you've sort of discussed them with your GP or qualified health professional. So, in the meantime, I wish you well. I wish you well for your long COVID recovery. Cheerio.